Okay, let's unpack this. Try to picture a population bigger than, say, the US, Europe, and Brazil all put together.
Wow.
Yeah, that's roughly how many people around the world experience significant disability. We're talking an estimated 1.3 billion. And that number, it's actually growing.
It is, mostly due to shifts in demographics, aging populations, and also general health trends. But here's the thing. Despite this huge and growing group, the sources we looked at show something pretty stark.
Which is?
People with disabilities consistently face, well, significant barriers just getting the health care they need. And this leads to persistent health inequities.
Persistent health inequities. Let's translate that. What does that really mean, like on the ground?
Uh,
The research we've got paints a clear and, frankly, pretty unjust picture.
yeah.
Persons with disabilities, on average, they die earlier. They often have poorer health, poor functioning. And when health emergencies hit, they're affected much more severely.
And here's what's absolutely critical, what really jumps out from the data, is that these health differences, they aren't just an inevitable result of having a disability.
Right.
Many are linked to factors both outside and inside the health sector itself. Factors that are, and this is key, avoidable. That's the real problem here.
Avoidable health inequities. That's powerful. So what sources are guiding us today as we dive into this really vital issue?
We've pulled together quite a mix.
Yeah, we have. There's a comprehensive scoping review, really digging into those barriers to healthcare access. Then there's a major guide from the World Health Organization, the WHO, focusing on how to achieve health equity. We also have insights from a presentation about person-centered care, a specific look at telehealth, especially how it's working or maybe not working for rural folks with disabilities.
And importantly, an analysis of the Americans with Disabilities Act, the ADA, specifically looking at it in the context of healthcare here in the U.S.
It's a good stack. Gives us that big picture, the global strategy, but also, the specific granular challenges and the legal tangles.
Exactly.
So our mission today, take all this, unpack this really complex web of barriers piece by piece, explore the legal side of things, and then, crucially, highlight the concrete strategies and tools being developed to make health systems truly inclusive.
Yeah, moving towards solutions.
Exactly. And as we go through this, think about your own community, maybe your own experiences. What really stands out to you about this fundamental issue of fairness in health? Let's start by pulling apart these barriers people are facing. Where do we begin?
Okay, let's set the scene. When you think healthcare access, your mind probably jumps straight to like the doctor's office or the hospital.
Sure.
But the sources make it really clear the challenges often start way before you even get near the door.
Right. Let's talk about the world outside the clinic first. The environment, those broader social determinants of health.
Yeah. One source really highlights things that aren't, strictly healthcare issues, but create huge hurdles. Think about poor urban infrastructure, maybe local violence making travel unsafe, or something really fundamental like just a lack of accessible public transport.
Totally. If you physically can't get to the appointment safely and reliably, it almost doesn't matter how good the care is inside, does it?
Exactly. That's the first layer, you could say. These external factors, foundational access issues. And then if you manage to navigate that, you hit the barriers inside the health system itself.
Systemic issues, service delivery problems.
Right. And the list there is pretty significant, too. The scoping review points to things like a lack of healthcare professionals who have the right training, or even just having the specialized equipment needed for continuous appropriate care.
And the physical barriers within the facilities themselves, these are incredibly common.
Oh, yeah. Think about the whole journey. Getting from your transport into the building, finding accessible parking. Can you actually get through the entrance in a wheelchair? What about the pathways inside, getting into wards, examination rooms, even basic things like accessible toilets?
It's everywhere.
It can be. And one source mentioned something interesting, that sometimes facility staff feel a bit uneasy when their accessibility is assessed, which really underlines the need to frame it not as like pointing fingers, but as a partnership. Let's work together to identify what's needed and make improvements.
That partnership idea feels really important.
Yeah. Okay, so beyond the physical stuff, communication is another massive barrier.
Huge. We're talking about things like signage. Is it readable? Is it in Braille or large print?
Or getting critical health information in formats people can actually use. Maybe large print, maybe Braille, maybe simplified language for someone with an intellectual disability. Or needing a sign language interpreter and one just isn't available. Right. If you can't read the signs to find your way, or you can't understand the information about your own diagnosis or treatment plan, well, you're effectively shut out, aren't you? You can't make informed decisions about your own health.
Yeah, completely.
And the sources also point to maybe more subtle but equally damaging forms of discrimination.
Like what?
Well, the ADA analysis mentions things like refusing to serve patients who get labeled as disruptive.
Which could just be a misunderstanding or the facility lacking capacity.
Exactly. Or lacking capacity to support certain needs, or even sometimes discrimination based simply on what kind of insurance plan a person has.
Ah, yes, money. That brings us neatly, or maybe not so neatly, to the financial and coverage obstacles. This area seems particularly complex.
It really is. It's not just the cost of the actual appointment or procedure, it's all the associated costs.
Right. Getting transportation there, maybe needing to pay for an interpreter out of pocket, or having a support person take time off work to come with you. The lack of financial protection for these kinds of costs is a huge barrier.
And the way insurance plans and health benefits are actually structured, that can be a real minefield.
How so?
Well, some plans might, mention including disadvantaged groups in their policies, but the sources show that discrimination based on disability or pre-existing conditions can still absolutely happen. Often it's in how the coverage is applied, or even how it's designed in the first place.
Okay, this is where that ADA analysis gets really interesting and maybe a bit frustrating.
Yeah,
It seems U.S. courts often draw this fine line, a distinction between discriminatory administration of a health plan, how it's run day to day, and discriminatory design, what the plan covers or excludes from the get-go.
that's right. And discriminatory administration, like how decisions are made about accessing benefits that are technically covered, that might be something you can challenge under the ADA.
Okay.
But discriminatory design, the actual choice of what the plan covers or excludes. Courts tend to view challenging that as requiring a fundamental alteration of the plan itself.
Which makes it much harder to fight legally.
Much harder.
Yeah.
Often impossible under the current interpretations of the ADA.
So give me an example.
Okay, imagine a plan covers physical therapy,
Mhm.
but then a reviewer denies it for someone with a disability based on some, I don't know, unfounded or biased opinion about whether they'll really benefit. That could potentially be seen as discriminatory administration. You might be able to challenge that.
Okay, I follow.
But if a plan simply doesn't cover, say, certain types of essential assistive technology like wheelchairs or specific kinds of rehabilitation services that many people with disabilities need but aren't part of the standard package,
Yes, design.
that's often seen as discriminatory design. And challenging that exclusion, that's where people run into major legal hurdles according to the ADA analysis. Yeah, and even the big landmark Supreme Court case, Olmstead, the one about the right to receive public benefits like Medicaid in the most integrated setting, even that case acknowledged this tension. The court basically said states don't have to spend more than their plan already allows. They have to move at a reasonable pace to reallocate resources. But it didn't mandate fundamentally changing the design of what's covered if it alters the program.
So there's this sort of legal gray area, a lack of really clear federal guidance on exactly when a benefit denial or a coverage exclusion crosses that line into illegal discrimination for people with disabilities who are trying to access covered care.
That's a good way to pull it. It leaves a lot ambiguous, a lot up in the air.
Okay. And layered on top of all that, we have the attitudinal barriers.
Yes, ableism, just sheer stigma. In society generally, and unfortunately sometimes within healthcare settings themselves.
I remember one source had a word cloud, and ableism and stigma were huge, right in the center.
They were. And this isn't just, an abstract idea. It directly impacts how providers communicate, the assumptions they might make about a person's quality of life or capacity, and ultimately the quality of care that person receives.
Which is why addressing it through medical training, through cultural competency curricula, is highlighted as so essential.
Absolutely. Building a healthcare workforce that actually understands and respects disability is crucial. Non-negotiable, really.
Okay, one more barrier area before we move to solutions digital barriers.
Right. Particularly highlighted in that source looking at telehealth use, especially for rural individuals with disabilities.
Telehealth seems like such a promising idea on the surface, doesn't it? Like it could bridge some of those geographical gaps we talked about.
It does have potential, definitely. And the studies show users often have positive opinions, and it can lead to some functional improvements. It can be really helpful for managing chronic conditions or accessing mental health services remotely.
Oh, there's always a but.
There is. As the source makes clear, Its full potential, particularly for this group, is severely limited by some significant specific barriers.
Likes.
Lack of reliable broadband internet, especially in rural areas, technology that just isn't designed accessibly from the start, maybe inadequate digital literacy or training for both patients and sometimes the clinicians too,
Right.
and even regulatory hurdles issues around how telehealth services delivered to a patient's home are actually reimbursed by insurance or public programs.
So even a tool that looks like a solution can bring its own set of accessibility challenges. Wow, that is quite a landscape of hurdles people are navigating just to get basic health care.
It is complex, yeah.
Hmm.
But the good news is the sources don't just stop at identifying problems. They also lay out some pretty clear strategies and, pathways forward.
They really do. And this brings us to the action side of things, strategies and solutions for building genuinely inclusive health systems. The WHO Global Report and that guide, they're a really powerful call to action here.
There they are.
They state it pretty unequivocally. Addressing these health inequities for persons with disabilities isn't just, a nice to have or about fairness alone. It's actually non-negotiable if we want to achieve universal health coverage and those big global health-related sustainable development goals.
And the WHO guide specifically pushes countries to make their health sectors inclusive, really emphasizing that this needs to happen by strengthening primary health care.
The primary care is the foundation.
Exactly. And they propose 3 core principles to guide action. 1, always put health equity right at the center. 2, actively empower and include persons with disabilities in every single step. And 3, monitor the impact of whatever you do specifically for them, not just looking at general population stats.
I really like that second principle, empower and include. It shifts the frame, doesn't it? It's not about health systems doing things to or for people with disabilities,
No.
but working with them. This whole theme of partnership and inclusion, it feels like maybe the most critical takeaway from all the sources that talk about solutions.
I agree. The strategies they outline include things like partnering directly with the disability community, involving them authentically in research, in planning, in decision-making. It really embodies that core idea. Nothing about us without us.
And the WHO guide gets practical about it, too. How do you actually do that?
Right. It talks about forming diverse working groups. And crucially, these groups are required to include representatives from organizations of persons with disabilities, OPDs.
So their lived experience is baked in from the start.
Exactly. Their insights, their experiences are placed right at the core of developing solutions. There was an example from Montenegro, I think, showing how essential having OPDs at the table was in actually shaping their National Health Action Plan.
And it's not just about the formal organizations, right? The guide also talks about individuals?
Yes, exactly. It recommends holding consultations not just with OPDs, but directly with individuals and their families. And, importantly, structuring those consultations carefully. Maybe holding separate groups based on gender or location or type of disability, just to make sure you're capturing a really diverse range of perspectives. And they stress providing the necessary accommodations so people can actually participate fully.
Things like accessible transport, interpreters, support people.
All of that. And making sure facilitators use communication methods that work for everyone in the room.
There was a quote from Tanzania in one of the sources that really struck me.
Oh yeah, I remember that one.
It basically said, the action plan developed is full of our opinion. We counted on our participation. We therefore made it, and it is ours. It will serve our purpose.
That says it all, doesn't it? That sense of co-creation, of ownership. It's incredibly powerful, and you can see why it's necessary for making changes that actually stick and work.
Absolutely. So the WHO guide also gives a structured way to even begin this work, starting with an assessment.
Yes, a situation assessment. It involves looking at specific strategic entry points within the existing health system, collecting relevant data about disability inclusion, and using tools provided in the guide to evaluate where things stand right now.
So you get the evidence first.
Precisely. It provides that concrete evidence of where the gaps are, but also where the opportunities might lie, which you need to build effective action plans.
And then, based on that evidence, the working groups design the actual action plans.
Right. Making sure they're integrated into existing health sector priorities, not just some standalone disability project. This means clearly identifying who's responsible for what, setting realistic timelines, allocating the necessary resources.
And crucially, budgeting for OPD participation.
Yes, explicitly budgeting for the resources needed to support meaningful participation from OPDs throughout the entire process. Examples given include things like setting up specific technical working groups focused on disability or developing guidelines to make health insurance plans more inclusive in practice.
Okay, so those are the big planning steps. What about tackling those attitudinal barriers we talked about earlier? Ableism and stigma.
Yeah, the strategies address that directly too. It means tackling stigma head-on through medical training, incorporating disability cultural competency into the core curriculum for all healthcare professional schools.
If ableism is a barrier, you have to educate the workforce. Makes sense.
It's fundamental. Building a workforce that is prepared, comfortable, and competent in serving people with diverse disabilities is absolutely non-negotiable.
And then improving accessibility and quality, it's more than just ramps, right?
So much more. Yes, physical ramps and accessible buildings are vital, but it's also about the communication methods, making sure services are truly available when needed, affordable and accessible in, like, every sense of the word, and ensuring the care itself is effective, safe, and efficient.
And connecting this back for you, the listener, why does something seemingly small, like accessible signage or maybe a height-adjustable exam table, matter so much?
Well, think about it. Without clear signage you can read, you might literally not find the right department. Without that height-adjustable table, you might not be able to physically get onto it for a necessary exam, maybe a mammogram, maybe just a basic physical.
So it directly impacts your ability to actually receive the appropriate care you need.
Precisely. Now let's quickly revisit technology, telehealth.
Right. Potential, but caveats.
Exactly. It does hold potential for improving access, especially maybe in rural areas, as that study noted. People using it often report positive experiences, some functional improvements. It can definitely support self-management of conditions, access to things like mental health services.
We still have those significant limitations.
We do. As we discussed, the sources urge caution. Its full potential for this population is really held back by those persistent barriers. Lack of reliable internet, tech that isn't accessible by design, the digital literacy gaps for users and providers, and those tricky regulatory and reimbursement issues for home-based telehealth.
So it's a tool with promise, maybe an emerging tool, but it needs very intentional, inclusive design. It's not a magic bullet.
Not at all. And, to track whether any of these strategies are actually working, making a real difference, data and monitoring are absolutely essential.
You can't manage what you don't measure.
Basically, yeah.
Yeah.
This means actively collecting disability data. And crucially, disaggregating it, breaking it down by factors like race, gender, language, cultural background, location.
Why is disaggregation so important?
Because disability intersects with all those other factors. You need to see if certain subgroups within the disability community are facing even greater barriers. It also means using disability-inclusive indicators to track progress, to really understand the actual impact on people with disabilities themselves.
Because if you don't measure who is being left behind or who is benefiting, you can't possibly know if you're truly achieving equity.
Exactly. And one final point that came up, advocacy.
Yeah.
It's highlighted repeatedly as a key driver for change. Navigating these complex systems, healthcare, insurance, legal frameworks, often requires support. And advocacy efforts, both individual and collective, have been absolutely critical in achieving major legislative changes, like the ADA itself, and constantly pushing for improved access to services on the ground.
It provides that necessary push, maybe that guidance, to break through inertia and really achieve systemic change.
That seems to be the case.
Wow. Okay, we have definitely covered a lot of ground here, pulling from all these different sources. It's really clear that achieving health equity for people with disabilities is just this incredibly multi-layered challenge.
Yeah.
You're battling physical barriers, communication barriers, financial ones, systemic issues, those deep-seated attitudinal barriers, all at the same time.
And legal frameworks, like the ADA here in the U.S., they're essential foundations, absolutely. But as we saw, the sources show they also have real limitations, especially when it comes to challenging the fundamental design of health coverage.
Right. And critically, tackling all these challenges seems to require these really intentional, on-the-ground strategies that fundamentally reshape health systems, moving away from maybe older traditional models towards something genuinely inclusive.
Yeah, that's the goal.
But I think if I had to pull out one core message that echoes across all these materials, it's that the most effective, the most sustainable solutions, they have to be developed in genuine partnership with persons with disabilities themselves.
Absolutely. Centering their voices, their agency, their lived experiences.
It's not just about changing systems for them, but
Yeah.
fundamentally building systems with them as equal partners from the very beginning.
That collaborative approach, that co-creation, is highlighted again and again as the path forward. It leads to solutions that actually work, that fit the need, and that are owned by the community they're meant to serve.
Okay, so let's leave our listeners with something to mull over based on this deep dive, particularly thinking about that legal piece we discussed in the U.S. context.
Okay.
Consider that really complex distinction the courts often make under the ADA, that line between discriminatory health coverage design and discriminatory administration. Even as we see global efforts, national strategies pushing hard for more accessible services, more inclusive plan administration, how might that specific legal interpretation here continue to be a major hurdle? How does it really impact whether people can effectively challenge barriers to getting the specific care they actually need if that care is simply excluded from the plan's fundamental design in the first place?
It's a critical question. It really forces us to think about how legal protections can evolve, how they can better align with the lived realities of healthcare needs for people with disabilities, ensuring not just access to the system, but guaranteed access to the necessary care within that system. That tension between the legal framework and lived experience is definitely a key point for future progress.